you can see that the double lumen tubes have a proximal oropharyngeal curve and a distal bronchial curve, which are at 90 degrees to each other. So one of the reasons why novices struggle or an inexperienced thoracic anesthetist struggle is because you can see that it's a long, broad structure. This is the outer diameter of a 8-sized single lumen tube, which is the normal maximum size which we use. And this is the 37 size. Okay, so it's quite big. And another small input I want to give here, especially when you're doing it for the first time, is this is the Y-shaped clamp which we connected to the double lumen tube. Okay, this is the connector. So if we had to collapse the lung, so first we clamp the tracheal lumen. So clamp on this part and not here. Okay, and then you open this part. So when it happens, we will ventilate the left side and the right lung is open to the atmosphere and it will collapse. So coming to the steps, you this is how you prepare. I will allow it to play along. Okay, and in the meantime I will show you how you do it. So you do a good laryngoscopy. You don't need to use a video laryngoscope. You introduce the double lumen tube with blue curve facing anteriorly, or the proximal bronchial curve facing anteriorly, and once it crosses the trachea, I will rotate it by 90 degrees and advance till I get a resistance. Then you connect it and then inflate the bronchial lumen and start ventilating. Okay, so if you see what is happening inside, you should see the blue curve entering the trachea. Once the blue curve enters the trachea, you can rotate it by 90 degree and advance. So there's a bit of controversy whether to take out the stylet or not. If it's a new tube, it will have adequate rigidity and it will maintain the shape to go in. So if you're re-sterilizing the tube, some people prefer to have a stylet, but I will try to do it as traumatic as possible and take out the stylet. So coming to the clinical confirmation. Clinical confirmation is done with auscultation. You do a bilateral auscultation. You should be able to hear air entry on both sides with the tracheal cuff inflated with about 4 or 5 centimeters of air. Once this is done, what you do first is clamp the tracheal lumen. Once you clamp the tracheal lumen for a left-sided DLT, you should not be here and open it up. You should not be hearing any air entry on the right side, and you should be able to hear air entry only on the left side. Okay. Similarly, at this particular point, we have not clamped we have not inflated the bronchial cuff. So there are two options here. One is try to hear for an audible leak and put about 1 to 3 ml of air in between. Other option is to put the patient on ventilator. If it's an adult patient, give it a tidal volume of 300 ml and look at the expired tidal volume. So ideally, it should be within, you can have only about 10 or 15 ml of leak. So titrate your bronchial cuff volume according to that leak, and that will be a good enough volume. So again, with the modern ventilator, you can actually see the airway pressures. So for example, if your airway pressure was about 15 and after you start bundling ventilation, it has gone to 35, that means it's probably malposition. The tube is probably too much in, because otherwise airway pressure should not be going beyond 30, and with more than a peak pressure of 30, you will struggle and can produce acute lung injury. Okay, so we should see the position appropriately. Okay, so there is a clinical confirmation and you have to do with the other side. So when you unclamp the trachea and clamp the bronchial, you should be able to hear air entry on the right side and nothing should be on the left side. But this is clinical confirmation. And if you try to inflate with too much volume, you can hear a bit of sound on bilaterally. So that is why previously we had a hypoxia of about 40%. So now coming to the fiber optic confirmation, what you do first is to go through the tracheal lumen. Okay, when you go through the tracheal lumen, what you should see is tracheal rings anteriorly and trachealis muscle posteriorly. and you should be able to identify the primary carina. The tracheal rings anteriorly, trachealis muscle posteriorly, and this is the primary carina. Primary carina is that sharp structure. Okay, and once you cross the primary carina, you should be able to go to the right side and enter the right upper lobe. Right upper lobe has a typical trifurcation or a clover leaf shape, which is right apical anterior and posterior, and then you can go to the right bronchus intermediate. So it's very important. If you are not gone and visited Toronto General Hospital's bronchoscopy simulator, it's a good worthwhile exercise. Okay, once this is done, we have seen the blue curve just distal to the carina. That is good enough. Okay, so now you go to the other side. So you come out of the tracheal lumen. So here I have pushed the blue curve a bit more inside. Okay, this is for you to make you understand the margin of safety. Once I have done it, we'll go to the left side. Again, you clamp the left side. I'm doing it, I'm showing an unedited video because you need to understand that these things doesn't take time. Okay, so when you go to the left side, you can see a structure. Okay, is it a left-sided secondary carina? You can see this. Is it a secondary carina? I will say no. I'll tell you why. Okay, because here the tube was initially inside that part. Okay, that is the structure we were seeing. Okay, so you need to come here, and this is the left side secondary carina. Okay, there is a left sided secondary carina. So a bit more inside, the tube would have gone the left lower lobe. So that is the margin of safety. Coming to the right sided DLT, again, the same procedure. First, go through the tracheal lumen. When you go through the tracheal lumen, what do you need to see? You should be able to see the primary carina and the blue curve distal to the primary carina. Then you enter the left side. Okay, so it's important for you to be familiar. Okay, this is the left-sided secondary carina. Okay, again, when you go through the bronchial lumen, okay, here we have an additional job. Here we need to make sure that the slot for the right upper lobe is aligned with the right upper lobe takeoff. So this is the bronchus intermedius, lingula, and the lower lobe. Normally, the trachealis muscle enters the lower lobe. So this is the slot. The slot needs to be aligned. Once the slot is aligned, we will be able to go inside and see the trifurcation. Okay. So this is the summary slide. When you come through the tracheal lumen,